Imagine you just bought a motorcycle, you're going to work, and overnight, you fall, lose the strength in your arm, experience excruciating pain, and you no longer feel as useful as you did before. This is the nightmare for someone who has just suffered a brachial plexus injury. Today I am here with Deborah, who is an occupational therapist, a hand specialist, and a specialist in brachial plexus injuries. We are going to talk about the patient who just fell off a motorcycle, just discovered they have the injury, and what to do so that you can live better after this problem. We will give useful tips that you can use at home, and also for you, who are family members of someone who suffered the injury, what you can do to support your relative. Deborah, when a patient who has just suffered a brachial plexus injury comes to your office, how do they arrive? Do they come with their head held high? Do they arrive sad, happy? What are their expectations? After entering your office?
It depends on the doctor, right? Some doctors provide more information, others not so much. And the patient often comes to me with a significant gap in this information, right? They are expecting movement, right? They don't really know what will happen to them. So, most of them are plexus patients, are young people, fully active in their work life, right? And they don't. These are severe cases. They end up not having much movement in the upper limb. Sometimes they only have more shoulder movement. And they usually arrive accompanied by their mother or sister. And then they arrive at this moment and they kind of test me to see if my information will be the same as the doctor's, to see if it will give them another expectation, how it will be, will I leave here moving my arm?
But is the expectation good or bad? What do they have? Do they arrive after seeing the doctor, like, let's go, let's try to improve this? Or do they arrive like, I don't think there's much to be done, I'm here just to fulfill the schedule? What do you sense from them? Does the specialist doctor help at this moment? Does he support or does he hinder and then demotivate the patient too much?
I think the specialist doctor supports, encourages the patient to seek treatment, the correct treatment. That's what I've seen. Sometimes it's not the rule, but it's what I've seen that the specialist doctor, when he understands the work, his intervention is always earlier, and he will encourage the patient to seek rehabilitation, in this case, the improvement of what he can improve.
Folks, so Deborah, she is an occupational therapist. She receives the patient after they have seen the specialist doctor, and today she is at a rehabilitation center, which is the patient comes to her after having already seen a specialist, a neurosurgeon, or a hand surgeon. So, she always receives the patient from someone who is specialized. I often receive patients who have already seen another doctor, who is not a specialist, who sometimes motivated the person. So, that makes all the difference. Her experience regarding the expectations the patient arrives with is better than mine. My patients usually arrive devastated, because they saw a doctor who said they would stay that way for the rest of their life, and the doctor doesn't even know if surgery can be done or not. They've never seen the surgery, never seen the treatment. And sometimes, the person doesn't even need surgery, but they were told they would stay that way. So, this first moment, for me, is very important, right? Because the person will remember the first sentence they heard when they sat in front of the doctor, which is, either it will work out, we'll do something to improve, or you'll stay this way for the rest of your life. So, this is very important. If you're a doctor and you're watching, be careful with the words you use, and be absolutely sure of what you're saying. Because if not, you might end up demotivating someone who could significantly improve their injury.
That's right. And I also see, Thomas, in relation to this, even the responsibility of us as rehabilitators. Because rehabilitating the plexus is not easy. Even though it's the C6 root, C7 root, it's very different. One patient to another, and if the therapist really doesn't have mastery, they can't do a good job, right? And many times, when you get the patient to achieve half of a bicep curl, they already leave super motivated, right? Because they arrive one way and leave another. So, I think like this. The first part is the doctor, for sure. The responsibility is theirs to try to focus and encourage the patient, but also the one who rehabilitates. Because if you don't have the capability, if you really don't have the knowledge of how to treat, you also kill the patient. Kill, as I say, the expectation.
Kill the chance. So, it's a young patient who started his job, bought a little motorcycle, went to work, went to make deliveries, or was traveling, and then suddenly, he crashes the motorcycle, which he loved riding. So his biggest dream, his greatest joy, which was riding a motorcycle, turned into a nightmare and became the cause of his current suffering. Then he loses the strength in his arm. He, who was a provider for the household, or an initial provider for the household, became someone who needs special needs. He might have pain. Very intense, and from one day to the next. That's his life. So, he wakes up in the morning, one person goes one way to work, another goes another way to do something else, and he stays there. He watches TV with neuropathic pain. And then, our role as doctors and rehabilitators is to make this person active again. Because we don't know what the outcome will be, if he will get better. 100%, 90%, 80%, 30%, or not improve at all. We know that if the person overcomes it, they become active again. Even if it's with just one arm or with the arm they injured, having a significant gain in strength. Now, Deborah, I want to know something. The patient who comes to you. From a doctor, how do you know if this doctor is a specialist, if it's worth sticking with them? And when you see that they are not a specialist, that they don't understand what they're doing? And maybe it would be interesting for you to refer them to another specialist doctor?
So, Thomas, today, my reality is that I only receive patients from specialist doctors. My reality is not to take patients who came from other places, from other doctors, let's say. And in the hospital, the patients, they all already come from the specialist. So, if for some reason we get a patient there who hasn't been seen by a specialist, we ourselves diagnose that the person has a plexus injury and is not seeing a specialist, we refer them ourselves. And in the office, my reality is that they already come from the specialist.
So, if you get a patient, for example, who is with a doctor that said just do rehabilitation and it will get better, and then you see that they have a serious injury, no tests, you will probably refer them to someone. Yes, right. So, I ask this for the following reason. For me, many patients come who see me on the internet, know me, and then we make the diagnosis, or they already come with the test ready. But I see that sometimes patients go to a doctor who is not a hand surgeon working in the area, not a plastic surgeon who does microsurgery, nor a surgeon who works with peripheral nerves. And then this doctor simply says, no, keep doing physical therapy. If in a year you don't improve, then we'll refer you. A year is already too late. Most injuries, after a year, you can no longer perform the surgery. For nerve transfer, you end up having to do a reparative surgery, which has much inferior results. So that's why I ask. About what you mentioned, Deborah, that usually the male patient. Most of the time, although there are also women with plexus injuries, I've performed surgery on some women, but usually this patient comes either with his mother, or his sister, or his girlfriend, who takes care of him at that moment, because when a man has an accident, he throws everything up in the air. And then the strong woman comes, who embraces him and helps. I wanted to know from you, what advice do you give to these women to help them assist him? Because I see there's a fine line between doing everything for this patient and ending up spoiling him too much. Him becoming a completely dependent person for a very long time, and also not helping and leaving him there, and he ends up not progressing. What do you think is the right approach? What advice would you give to this person to help but not spoil too much?
Yes. If we think about it, Thomas, the person who has, at this moment, they have one arm, right? So, with one arm, the person is very independent, very much so, even in the kitchen. But I understand that, at this initial moment, the family might not be able to handle it well or have tips for kitchen activities. But bathing, dressing, the person can do everything alone. They don't need help. I think that, many times, we, as a family, if we coddle this person too much, we will deprive them of the opportunity to be independent. There, after 2 or 3 years, she could really have a better path. Because we are doing everything for her. I understand the person. As you said, a young person, it's as if their life was taken away overnight. But as a family, we have to support, and support even the emotional aspect. But we also have to say, no, come on, can you do this? You can do it. So, because sometimes the person enters a depressive process, I'm not going to say they fall into depression, but they enter a depressive process. Grieving process. Grieving, yes, let's say you said the right word. Because then they see everyone with their life and they are without their life. So, what do we, as rehabilitators, as a family, need to do? It's to try to give back what they can do from the life they had. So, some things in the kitchen, at first, the person won't be able to do. But we, as therapists, have some strategies. Because today the person can cut food, can cook, can eat. The biggest difficulty with the plexus is really eating with a fork and knife, because they won't have the other arm to support. Unless they have a good hand, we can try to make an adaptation for them to hold the fork with the good hand, with the plexus hand, and with the other hand, they use the knife to cut. But aside from that, we have adapted plates, adapted cutting boards, the person can peel fruit, we do quite an interesting job with that. So, the family has to put themselves in that position. I think the family suffers a lot together, especially the mother and sister. But keep it, suffer, in the room, but when you're near him, no, let's do it.
Push him.
Push him.
For him to evolve.
Because this will be very important for him in the future.
And tell me something, I always think like this at home. If I only had one arm, what would I do at such a moment? Then I look at the toothpaste, and I'm like, man, toothpaste, you have to open it, hold the toothbrush. Actually, you don't need to hold the toothbrush, you place the toothbrush there, you turn the toothpaste, and you squeeze it. And there are those toothpaste tubes that are a click, right? You click, place it, and close it. Yes. But there are some activities that are designed for you to use both hands. For example, I have a filter at home, which is a water filter where you have to hold the glass. And with the other hand, you move it up and down. So, it's something made for people with 2 hands. What do you say to someone in their daily life, like, hey, you need to change this here, because this isn't made for you? To be able to use it, you have to adapt. What do you usually tell someone? Because otherwise they won't be able to use it.
So we do an assessment, exactly for that, right? What are the things they have at home, right? To try to make changes. The story of the toothpaste, even if you don't. There are people who don't have the skill to do it with just the other hand.
I trained, I can do it.
So, but is it your dominant hand or not?
It's because I'm ambidextrous.
Yeah, you're ambidextrous. You're a surgeon. So, there are people who still injure their arm, which is the dominant one. The other, then it's one arm. So, but we have other techniques. We can manufacture, or there are already devices on the market where you put the toothpaste there and you just place the toothbrush. Regarding opening bottles too, right? Because then the person can place the bottle on their leg and open it with the other hand. So, there are cutting nails, right? You can do it with just one hand. So, we have many adaptations that can be made.
Yeah, those for taking a shower. You buy that device that you put on the wall and then you press it while you grab underneath. So, you grab the shampoo like this, right?
Yeah, or you can put that. The soap dispenser, right? Thomas, where you put the soap, the shampoo soap, anyway, in these dispensers and you just press with one hand.
Exactly, because sometimes you have to open the shampoo, put it in your hand, while the other does this, can't do it.
No, the dispenser will do it.
The dispenser does it, cool.
Yeah, sponge, right? So sometimes we make one. There are brushes, right? That can wash the other side, so you can do it. I think the hardest things are really in the kitchen. compared to other things, people end up realizing it. And I think one really difficult thing to do is cooking. Because cooking, the pot, it moves, right? So, then we have to create some situations so the pot doesn't move when the person is stirring.
And the risk too, right?
Yes.
So, folks, what we want to say is this. A tip for patients who have had a plexus injury for the family is this. If you're going to serve a dish that has meat, cut the meat for the person who had the injury, because they can't cut the meat with just one arm. However, you don't need to feed them the food.
Exactly.
Why? Because you're at a table, everyone can eat, they can eat with just one hand. It's difficult, sometimes the food moves when you're serving it on the plate, but they will manage.
Nowadays, there are those plates with suction cups, you know? So, the plate doesn't slide, right? And then it becomes easier, so there's no risk. Like, the plate needs to have a suction cup where you can put the non-slip mat under the plate, which also holds it in place.
So, in the end, there's no excuse for the person to need help with everything.
There's no excuse. And this is a task we have to do. As a rehabilitator, we have to go the first, the second day, it's just evaluation, we ask questions, do this anamnesis with the patient and be able to say, are you doing this? No, I'm not. So, now you can start doing this and begin to guide and establish a routine for them. And every time they come, follow up. And it's not just an exercise routine, it's a routine for these activities.
I know, folks, Tiago, who is a mechanic in the United States. He does with one arm what people can't do with two arms. He drives those trucks that tow other trucks. It's something that people with two arms find difficult. So, what we want to say is this, if you do everything for the person who just had the injury, they will end up wanting you to do everything for the rest of their life. And they will convince themselves that they really can't improve. When, in reality, they can become someone much stronger, much better than they were before the injury. Even if the arm isn't helping that much.
That's right, and I think there are a few things. I've also worked with people who had plexus injuries and are mechanics and are working. One who repairs washing machines, and he himself takes the machine out of the house and brings it to his own home. With just 1.5 arms, so to speak, he does everything by himself. But what's the difference? It's the person's motivation, right? The motivation that the person has. Like, am I going to just stand still watching, or am I really going to go after it? And other things, too, that I keep thinking about. Many times the person really won't be able to return, Thomas, to that role. And they get stuck on that, you know? For example, let's talk about the mechanic story. Not everyone will be able to return, right? They can't. Some managed, sometimes because of the injury, and some have a much more severe injury and couldn't return. But they couldn't return to being mechanics, but they can do a whole range of other things. It's just that they get stuck on that, right? And that's the worst, or the hardest part for us to break through this situation.
Change the mental trigger that says, I can't, and in reality, I can. And I tell the family one thing, it's the following. Oh, he used to do, he liked. I say, folks, he didn't die, did he?
Yeah.
He's here, like he used to do. You need to change that verb there. He didn't used to do. He wasn't. He does. He is. We are going to treat the arm regardless of what happens. But he's still here and he has to fight to get better, right?
One thing, right, Thomas, that I just remembered, that patient we treat, who wants to ride a bike, right? So, I give a series of possibilities, but the person is in a situation, I think psychological, of facing it. And they can't even try, right? Because they're afraid of falling, getting hurt again. And because the proposal was, let's try to ride with the stationary bike, right? To see the movement that you're missing. Because sometimes it's not the movement that's missing. No. So, we see this a lot in plexus patients. It's what I say. Mental objections. Sometimes, the doctor spends very little time with the patient and can't notice this. This is a therapist's role. For me, the doctor.
I'm kind of crazy and I keep sending messages, talking to the patients.
I keep myself very dedicated.
I don't know if it's unique, because sometimes I get a bit crazy, especially since I talk so much with the patients. But I think, to understand this context, the person's life, you have to spend more time with them, understanding, watching them do things. And only a therapist can do that. The doctor, they won't do that. So, for me, that's really important. Because sometimes, what the person can't do, no surgery is going to fix. It's a tip, guidance, or advice.
Exactly.
Breaking a mental barrier of theirs, really. Go there, put on a splint and go. Sometimes, it's not the strength that's missing. It's you forgetting about this arm and doing it with the other. So, that's very important. Now, practical tips for you, who just had a brachial plexus injury. And you don't. No, because the doctor you saw didn't know how to explain it to you. Sling. Is it worth it when you just have the injury, not the patient who had surgery, you just have the injury, left the hospital, and are about to start rehabilitation, to use a sling all day? No. What do you recommend?
Not all day, but I am very much in favor of the sling, because the arm can hang down a lot, gravity pulls it, and this shoulder will become dislocated, causing the patient pain. So, we'll have one more thing to treat. And we don't have a good muscle to treat this dislocation. So, I am in favor of using a sling. When it's time, every hour, I ask them to take it off and do exercises, right? Like, let the arm loose and really stretch it in extension with the other hand. If you're on the couch, you can keep it supported. No need to keep it in flexion or too much in extension. Just leave it natural. Move the wrist and fingers a lot, but I am in favor. But I ask them to take it off every hour to do these exercises.
I'm a bit against using a sling. I don't know if you've ever seen my videos. I'm a bit against it for the following reason. My biggest fear is mainly because they are younger patients. Of getting used to wearing the sling. I think the ideal scenario is really intermittent, taking it off, putting the sling on, but my fear is the person using it continuously, because there are patients who use it all the time. And then, when they come to rehabilitate with you, how is their arm?
I don't see that difficulty, you know? Because we guide them a lot. On the contrary, it's harder for the patient to use the sling than to go without it. I see them all with their arms hanging loose. Right. The arm hanging loose. Yeah, I see that.
I prefer it because then they come in with a looser arm. The patient who stays too stiff becomes like a rock.
But the thing is, my rock is the shoulder, right? My focus is the shoulder, because then it really becomes. Sometimes, the person starts to have a lot of pain due to a dislocation. Dislocation.
Which patient do you see having more pain from a shoulder dislocation? Is it the patient with a complete injury or the one with an incomplete injury?
It's the patient with an incomplete injury. Incomplete, right?
Because the nerve is still connected, the shoulder falls and pulls, right?
But so, there are these differences in conduct. I don't think any of them are right and none of them are wrong.
None is right or wrong. We're both right.
What I think is that regardless of one or the other, the patient needs to be very well guided.
Exactly. And I think the most important thing is for the person to mobilize the joint, regardless of the sling.
And this, Thomas, I'm going to say here on national television, is that this is the patient's responsibility, not the therapist's. Because many patients say, no, I need to come, because my joint is getting stiff. They have already been guided. We guide. This is their responsibility. They are the ones who need to move to prevent the fingers, wrist, or elbow from becoming stiff. Because if they treat it like this from the beginning, they won't have stiffness while waiting for the nerve to recover, you understand? But if they transfer the treatment to us, then we won't succeed.
So, folks, here's the thing. The joint, it's the cartilage that keeps moving. This cartilage is lubricated every time you move. Since the muscle no longer pulls in either direction, it stays in the same position. And then what happens? The joint will stick in that position. And the tendon, for example, if my hand stays like this for 30 days, the tendon that closes shortens and this one stretches. The physical therapist or the occupational therapist can't stay with you all day, stretching your joint. So, what she meant is really that you need to move, stretch, because your muscle is no longer there doing that movement. And then her role will be strengthening neuroplasticity, adjusting some things to facilitate daily movement, and not releasing the joint, which should have been done by you.
Exactly. You mentioned neuroplasticity. That's something fundamental. In plexus injury, we then use imagery.
What is imagery?
Imagery is a technique for us to achieve neuroplasticity. So, the sooner we start, the patient had the injury, the sooner we start with. Neuroplasticity, hemogetics, is faster or easier because it is a facilitator. The patient's brain will try to find other pathways. So, research points to this. I see that many people go straight to the mirror technique. But the mirror technique is a means. It's not the only one. So, even within the mirror technique, you have various techniques within the mirror technique. And then, besides the mirror technique, you have imagery, which is what studies today say. There are plenty of studies for stroke patients, which we do with plexus patients. So, you try, through imagination, to activate their motor areas. So, studies say that if it's visual, like the person is watching a movie or a play, it even activates. Studies say this, that it even activates, but nothing activates more than if I say, Thomas, and you pick new appointments, 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 and you pick new appointments. You will find an environment where you like, where you had pleasure anyway. Oh, Deborah, I like coffee, drinking coffee. So, Thomas, let's make coffee. Then you go, the therapist, they guide you. You might not pick it up. You think you have a plexus injury, you won't be able to pick it up. But you will, imagine yourself, but someone else. Can I make an addendum?
Can I simplify for those watching? A study by Dr. Mariano, or I did my fellowship, talks about when a person has a nerve injury, meaning the nerve is cut, that region that was part of the arm, for example, starts to atrophy as if it were a stroke. Imagine if the person stops making coffee every day. So, that neuron that used to convince her that she could make coffee or move or do something, it disappears. And if the person goes 6 months, a year without doing it, it's not just the muscle that's atrophied, but that area of the brain that once believed she could do it now disbelieves and doesn't even remember if the arm exists. Exactly that. So, folks, this is extremely important. What it does is not let you forget that you can do it.
Exactly.
And then, when, if suddenly the movement returns on its own, or you have surgery and regain that movement, that area of the brain
ill exists. That's exactly it.
Very cool, very cool.
But the person has to imagine themselves doing it and not someone else, because there are several studies already showing this.
And we go back to that story of you encouraging the person to do it themselves.
Exactly.
Because for me, I don't know about you, if the person believes, they will get better. It greatly increases their chances of improving. That's where we find miracles, right? You say, wow, I can't believe this guy improved so quickly. He got better like this. We don't see this in people who don't believe in the response. No one is going to wake up in the morning and say, wow, doctor, it's been 6 months since surgery, my arm is back. Woke up in the morning, it was moving. That's not going to happen. So, it's through a lot of imagery rehabilitation and the person really believing in it. I have a question. It's important, which is the following. What do you see as the difference between a patient with an incomplete injury and a patient with a complete injury? I know it's a very big question, but I would like you to tell me, what do you feel? When one patient arrives, then another, do you think they are the same disease? No, because to me, they are completely different diseases.
I think they are completely different diseases, and I think that the one who has a complete injury, I think they are more susceptible to not believing, right? To really being in an endless world, right? I don't believe I see that.
Guys, complete injury. It's that patient who has an avulsion or a rupture, or like, they erase the information from all the nerves of the brachial plexus. if we were to understand it. In terms of imagery, it's as if this person's left arm suddenly disappeared from their brain. So, it disappeared, and what remains is the sequela, which is the lack of movement and the neuropathic pain that in this patient.
It's very important, right? Yes, exactly. Then we see many accounts, quite sad, really, regarding the pain, because I'd had patients who would go 2 days without sleeping and then sleep 1 day. So, they already knew when they wouldn't sleep. So, these were quite complicated accounts.
They would sleep out of exhaustion.
Probably because they were well medicated, but the medication wasn't effective.
And I know the answer, but I'm going to ask anyway. If you ask a patient with an incomplete injury, would you prefer to improve strength or pain? They usually respond that they prefer to improve strength because their pain is tolerable. And it gets better over time or even with surgery. And the patient with a complete injury, if you ask if they want to improve strength or pain, what do they respond?
The pain. I've had patients who said they would have preferred to have an amputation.
Yeah. And then there's no point in amputating because the neuroma is inside the spinal cord. They need to have the DRS surgery. And what do you do for these patients to improve the pain? What guidance do you give? What can be done at home first?
This neuropathic pain, duplex, Thomas, is very difficult. I'll tell you that there isn't. At least in my experience, I can't see anything I can suggest that improves it, you know? I don't have. No matter how much we know, let's try, do a desensitization, apply textures, I don't see it, right? I don't know if anyone has anything else, from a rehabilitation standpoint, if anyone has any technique.
I have a technique. No, it's not rehabilitation, no. Actually, what happens? It's my opinion, seeing the patients, talking, understanding. What happens? The nerves, in this case of the patient, who has a complete injury, he has no connection with the arm anymore. So, nothing you do to the arm will reach the brain. Everything you do for the brain, then it reaches the arm area. So, maybe mirror therapy works partially. We know it's complicated because it's a very intense pain. But I see that things in daily life greatly influence the pain, because that's what's left. So, I see that patients who avoid stressful moments improve the pain a lot. I have a patient who had an injury many years ago, right? I wasn't even practicing at the time. And then he is a complete evolution. He had the surgery a long time ago, back when it didn't have very good results. And he really didn't improve. Today, he manages the pain. And he says that when he rides his motorcycle, he goes to Chile on his motorcycle, stays there for 2 weeks riding. He doesn't feel any pain. None. He spends 15 days riding a motorcycle without pain because it's really neurotransmitters, right? Neurotransmitters, exactly. The pleasure of riding a motorcycle helps him alleviate the pain. If you're a wife, sister, mother, and you heard this, don't show the video to the person I'm talking about. And if he's watching with you, I apologize, okay? Don't ride a motorcycle. I don't ride a motorcycle. I'm even afraid to ride a bicycle because of how many people I've operated on. But really, the pleasure, the reduction of stress does help. It makes sense. And today, there's also a lot about diet to avoid pain. Which is also about diet to avoid inflammatory foods. These things, some studies are already talking a lot about this. But for a complete injury, in my opinion, the surgery that has the most results is dresotomy. Results, exactly. Great. And for a patient with an incomplete injury, can you help them with the pain? That is, they have part of their nerve still going to the arm. So, is there anything you can do to improve this pain? Another question. Do you work in the area where they have sensitivity or in the area where they lost sensitivity to improve their pain?
I use a very targeted laser a lot, where they say it hurts, or where they sometimes have a positive Tinel sign. I work with the laser in that area. I also use TENS too, in a parameter to improve the pain, in this case, on the whole arm or just in that specific spot. And the pain, this story of where there is sensitivity and where there isn't, I don't work much with that. I work where they say it hurts, regardless of whether that area has sensitivity or not. Because, you see, we often have patients saying, wow, it hurts here, but they can't really explain where it is. Oh, it's itching here, but they can't say exactly where it is. Or if it itches, they can't feel it.
It itches but doesn't itch, right? That's quite common in nerve injuries.
So, I don't really work much with whether an area has sensitivity or not. I focus more on the pain itself.
Yeah, you know me from the many patients I've sent to you, right? And you know that I do a nerve transfer, but I always work on the neck. And if there's a neuroma, I always reconstruct it. Aha! Because for me, reconstructing the neuroma helps the person improve their pain and greatly enhances the final result. Yes. You notice, there's a difference between the patient who only had a triple anastomosis, which is that shoulder surgery, from the triceps to the deltoid and from the hand to the biceps, which will improve movements. But doesn't reconstruct the neuroma they have, compared to the patient who was reconstructed?
Yes, because when you reconstruct this, it greatly improves the pain. And the pain, by improving the pain, he can improve movement because it makes it easier. So, many times, we can't work with some movements or in some ways because the patient is in a lot of pain. And then, if he is in pain, we can't even apply pressure. It's not in that sense. We can't perform the movement. We have to be much more concerned with the pain than with the movement because the patient feels a lot of pain.
What happens is the following. Sometimes the person has a nerve injury. C5, C6. There. We can improve the movements of these roots by making transfers down here. However, the importance of reconstructing this root is that it will help improve the pain. And the pain works as if it were shackles on people, pulling them back while you tell them to run. That's right. So, throughout the entire treatment, you will have to deal with improving movement along with fighting the pain. A patient who comes to us in the office says, "Oh, I'm getting better, but I'm in pain, I'm in pain, I'm in pain." So, it's something that will keep undermining and hindering a lot the person to the point where they might want to give up. So, treating this person's pain in parallel is very important. We can't always do it, right? We do everything. We use medication, we use conservative measures, but sometimes we can't. But there are things we can do from a surgical and conservative standpoint, right?
One thing that helps a lot is aquatic physical therapy, right? It helps a lot in the pain process, right? Even for the plexus patient. I think it has helped us.
Could it be a matter of temperature?
I think so.
Guys, so if you've just had a plexus injury, I sincerely hope you enjoyed this video and that it helps you in some way. I'll leave Deborah's contact, and I'll leave my contact below in the video. I hope you follow more of the videos and subscribe to our channel for more information. A hug.